This group of PowerPoints will address the question, why do we do what we do? There are many theories out there with different viewpoints, different categories that attempt to answer that question. Some are more useful than others. Some have historical significance, but perhaps are not so relevant anymore. However, all try to promote interventions consistent with the theory. Nurses need to be familiar with these theories. They propose to explain psychiatric disorders, and again, they form the basis for interventions in the clinical setting. Regardless of the theorist's point of view, the following universal concepts are embraced by all theorists. Theorists believe that all behavior has meaning. We don't do things haphazardly. The unconscious plays a role. Now, granted, a behavioral theorist, for example, is not at all concerned with what's going on in our unconscious. That, as opposed to someone with a more psychoanalytical point of view, believes that much of what we do stems from unconscious conflicts. Behavior is goal-directed, and the early years of life are extremely important. Again, regardless of the theorist's point of view, these are universal concepts. As part of the assessment process in psych mental health nursing, we must be aware of the presence of predisposing factors in our patients' lives. Those are those long-term situations which can exert a negative effect and lead one to experience long-term stress. Precipitating factors, on the other hand, can be referred to as the straw that broke the camel's back. An example might be the death of a loved one, a financial crisis, or a devastating illness. Psychoanalytic theory, as I know you are well aware, stems from a Freudian point of view and has much to do with the unconscious and the relationship between the id, ego, and superego. There are two words here which I want to review with you to make sure you're clear on, and that is transference and countertransference. These are two terms which are fairly commonly represented in the therapeutic literature. Transference refers to the client's thoughts and feelings that are rooted in the client's unconscious or past that are transferred onto the nurse. Now, this can be positive or negative and can subsequently hamper or move forward the process of therapy. Countertransference, on the other hand, refers to the nurse's thoughts and or feelings that may be rooted in the nurse's own unconscious that are transferred onto the patient. Now, it's generally agreed that this is rather unfavorable and tends to have a distinct possibility to move along negative lines and be counterproductive in the therapeutic process. We must remember that the interpersonal relationship between the nurse and the patient is about the patient. It is not a venue for the nurse to work out his or her own thoughts or feelings about people in his or her own environment. Ego defense mechanisms, also referred to as defense mechanisms, are considered protective barriers used to manage instinct and affect in stressful situations. They may be used to resolve a mental conflict, to reduce anxiety or fear, to protect one's self-esteem, or to protect one's sense of security. Depending upon their use, they can be therapeutic or pathologic because all defense mechanisms include a distortion of reality, some degree of self-deception, and what appears to be irrational behavior. Such mechanisms are supposedly in action by 10 years of age. The following is a list of some of the commonly used defense mechanisms. I suggest that you look over the definitions of these, and we will discuss them further in class. As I know you are aware, the psychoanalytical view of growth and development has a sexual theme. It is all about the genitals and pleasurable feelings. By now you are all well versed in Erikson's 8 social developmental stages. He believed that all of personal anxiety reflected social concerns. The humanistic theorists wanted to see more active involvement on the part of the therapist. Maslow is an example of a humanistic therapist. Recall his hierarchy of needs with self-actualization on top and physiological on the bottom. Recall B.F. Skinner with his operant conditioning, and Ivan Pavlov with his classical conditioning. Behavior theory is the study of directly observable behavior. The belief is that human behavior is learned. The focus is on the behavior, not the cause of the behavior. Approaches such as respondent and operant conditioning, reinforcement, punishment, generalization and discrimination, modeling and shaping are used to modify observable behavior. Behavior theory is often criticized for neglecting the cognitive and affective component. There is a strong research base. Cognitive theory emphasizes the role of thoughts in how people feel and act. Distorted beliefs lead to negative self-statements, which in turn alter behavior. So, we examine distorted thoughts, we sift through them, clear them up, and replace them with positive or growth-producing thoughts. This leads to behavior change. We will be talking a great deal about cognitive distortions and the role that they play in the interpersonal process. Researchers are increasing their examination of the biophysiological and the relationship to environment and early learning and other variables. Research is expanding and there are new findings constantly. The stress adaptation model, very popular in the nursing community, states that human beings are biopsychosocial adaptive systems who use coping mechanisms to adapt to both internal and external stimuli. This definition of mental health, which is embraced by the nursing community, is very similar and certainly reflective of the one put forth by the Joint Commission on Mental Health and Mental Illness, described in slide 24. Community mental health can best be described as a movement, an ideology, or a perspective that promotes early comprehensive mental health treatment in the community, accessible to all, including children, adolescents, the elderly, and individuals with chronic mental illness. It derives its values, beliefs, knowledge, and practices from the behavioral and social sciences. Mental health services provided in the community may include 24-hour per day emergency psychiatric care and crisis intervention, screening for clients being considered for involuntary admission to state mental health facilities, partial hospitalization and day treatment programs, case management, community-based residential treatment programs, aftercare and rehabilitation, consultation and support, and psychiatric home care. The primary goal of community mental health is to deliver comprehensive care by a professional, multidisciplinary team using innovative treatment approaches. The community mental health movement, often considered to be the third revolution in psychiatry, gained prominence in the early 1960s. Before this time, psychiatric treatment had occurred primarily in psychiatric institutions or psychiatric hospitals. In 1946, the National Mental Health Act provided funding for states to develop mental health programs outside of state psychiatric hospitals. This act also provided funding for the establishment of the National Institute of Mental Health in 1949. Early in 1952, an international committee from the World Health Organization defined the components of community mental health as outpatient treatment, rehabilitation, and partial hospitalization. Later in the decade, state-funded and federally programs mandated the broadening of services to include 24-hour emergency walk-in services, community clinics for state hospital clients, traveling mental health clinics, community vocational rehabilitation programs, halfway houses, and night and weekend hospitals. In 1963, U.S. President John F. Kennedy, who supported the improvement of mental health care, approved major legislation significantly strengthening community mental health. This legislation, the Community Mental Health Centers Act, authorized the nationwide development of community mental health centers to be established outside of hospitals in the least restrictive setting in the community. It was believed that these centers would provide more effective and comprehensive mental health treatment than often the remote, state-run hospitals that previously served as the primary setting for psychiatric patient care. In conjunction with these congressional mandates, states began the massive process of deinstitutionalization, moving chronically mentally ill clients from the state psychiatric hospitals back to their homes or to community-supervised facilities. This movement, a controversial and much debated social policy, occurred within the framework of the major and comprehensive social reforms of the 60s. The federally funded community mental health centers were also mandated to provide comprehensive services for this new population, some of whom who had been in institutions for as long as 25 years. We continue to have some problems in psych mental health. Yes, the community mental health movement did much to counteract the effects of institutionalization. However, we still have a huge population of institutionalized patients. Also, the problem that exists in our communities where the population does not want homes, shelters for some of these patients that have been institutionalized for years in their neighborhoods. We continue to fight the fight against homelessness and poverty. Noncompliance is a huge problem. Very often patients start to feel better, symptoms start to subside, and when that happens, many patients decide that because they feel better, they don't need their medication anymore, go off it, and the revolving door goes into effect, and they're back in the hospital again. You will see this happen over and over again in your clinical rotation. Conceptual frameworks and theories are nothing more than worldviews, ideas about how the world works. Various theories in psychiatry represent worldviews and are a way of thinking about people and the world. They all offer different explanations for human behavior and promote interventions consistent with their tenets to help people with psychiatric disorders. A common mistake of many in the helping professions is overzealously embracing one approach, believing that particular method to be the single most effective option for all people. Although commitment is necessary if a healthcare professional is to be competent and to make a difference with patients, a single-minded adherence to one school of thought is not helpful. A rigid and narrow view makes it impossible to treat people holistically and to adhere to the principles of an integrated psychosocial, biologic, and socio-cultural approach to care. Furthermore, forcing interventions related to one approach may make it impossible to reach and help people who would respond better to other options.